Good morning, immediate past chairman of the Nigerian Medical Association of Rivers State and current HOD, Professor C. Aleko. Good day, Dr. Nwazo Ernest, head of neurology unit, Rivers State University Hospital, consultant neurologist. Good morning, senior registrars, and good morning to all our online viewers. My name is Dr. Eche, the Assistant Secretary, NMA Rivers State, and today we have a collaboration with the Department of Internal Medicine, and we'll be celebrating the World Stroke Day 2022. We've had a very wonderful week. During the weekend, the department, via the neurology unit, in collaboration with NMA, had been in radio stations. We also collaborated with Reef Ethics, one of the programs of the First Lady of Rivers State. And for Saturday and Sunday, the department was all over all radio stations in Rivers State. And today we want to end the occasion by having a very important seminar. And then there will be a rally that we follow through after this presentation. We want to thank the head of department for the privilege to host this, and also thank the NMA chairman who will be here very soon for the collaboration. So not to keep us waiting, we'll be straight to the point, and we want to take the scientific section, the lecture. Let's put our hands together for Dr. Nwazo Ernest, the head of the Rivers State University Hospital. Welcome, sir.
Okay, thank you, Dr. Nietzsche. So let me start by thanking NMA Rivers State, NMA Chairman Rivers State, Dr. Robinson. I think so in a short while he's going to be here. I also want to thank and celebrate our respected HOD, Professor Sir Aliko. You're welcome to this seminar. Today we are giving a seminar in commemoration of the World Stroke Day 2020. So remember, every 29th of October is designated by the WHO as World Stroke Day. And this has actually been very important because of the burden of stroke, because of the public health significance of stroke. So this morning, I'll be sharing with us a few facts about stroke. It's not really meant to be a scientific talk, so to speak, emphasizing a lot of technicalities about stroke. Yeah, instead, it's supposed to be an enlightenment program. Yeah, just that sometimes it's difficult to present this kind of topic without bringing in one or two technical stuff and all that. So please bear with me, but I also assure that in the course of the presentation, if you need me to clarify one or two things, I'll be willing to do that. Okay, so let's start by revisiting a few concepts about stroke. Now, the old stroke emphasized so much about time, as far as stroke is concerned, they talk so much about time, with stroke being defined as acute onset, focal neurological deficit, of vascular origin lasting 24 hours or leading to death. But the new concept is less emphatic about that. There's no timing to it. So the emphasis here is that it is a focal neurological deficit of acute onset, quite all right. So cerebral dysfunction of vascular origin with objective neuroimaging evidence of a lesion. So irrespective of the duration of symptoms. So very, very important, you must understand this. Now, in talking about burden of stroke, 1 in 6 persons worldwide who have a stroke in their lifetime. And about 15 million people per year are expected to suffer a stroke. I mean, so this statistics is quite alarming, but that's actually the reality. About for 5.8 million deaths, are usually going to be due to stroke every year. And again, remember, stroke is the leading cause of death in people above 60, and the fifth cause of death in age range 15 to 59. Now, I've just included this study because it's actually a landmark study. So that started in the 90s in the United States of America. That's a Northern Manhattan stroke study. So it's actually, an important study that you can't do without when you're discussing epidemiology of stroke. So if you look at the graph by your left side, you're going to see the distribution of stroke among different races. So what stands out there is that Blacks are more affected than every other tribe. So among whites, Hispanics, Blacks are mostly affected. Experience more stroke than every other tribe. Then if you look at the graph, the chart on your left, and you're also going to see that stroke appears to, incidence of stroke increases as age advances. Now, talking about stroke mortality, now if you look at this world map, you can see those dark red areas. So those are actually areas with a lot of cluster of stroke burden in terms of mortality and morbidity. So I'm sure you can easily locate where Africa is. So you can see the clustering. So compared to the other parts of the world. So the other areas above Africa. So those are some of the Asian countries, and of course we share similar demographics, and that is why you have a lot of red spots on those areas. Then now in terms of disability adjusted life years. Okay, so this simply refers to as years lived with disability, as well as years of life lost. So stroke is still an important public health concern. Somebody comes down with a stroke. For instance, if he suffers a stroke at 40 and he's going to die at 80, so if at 40 he acquires a major disability, so he's going to live with that till he dies. So the burden is quite huge. Now, then, in terms of years of life lost, stroke still ranks quite high. Now, disability measure, you can look at the graph by your right. So disability measure, there is modified ranking scale. So you can see what's stroke. You can see actually the amount by which stroke, people with significant disability, so from different diseases and all that, you can see the distribution and how stroke contributes highest among other disability, other diseases that can give disability. Okay, so now talking about stroke epidemiology in Nigeria, the prevalence, according to Osun Toku was actually the foremost neurologist in Nigeria, existed in the 50s, 60s, and all that. And so he did a study in a rural population, I think Ibora. So the prevalence he got then was 58 per 100,000. So whereas the incidence figure he got was 26 per 100,000. So much later, so many other hospital-based studies start emerging. So Professor Gu of Ogun State University then did an important landmark, hospital-based study. So that was even published in Stroke Journal. And so he got this data. Stroke accounting for 0.9 to 4.9% of hospital admissions, 2.8 to 8.4 of all hospital deaths. So this is still to tell you how serious the issue of stroke is. Now, male-female ratio is about 1.7 to 1. With cerebral infarction, the peak incidence of cerebral infarction happening around the 7th decade. Then, whereas hemorrhagic stroke peaks around 6th decade. Then in his study, he discovered that cerebral infarction accounted for 14% of all strokes, whereas ICH, that's intracerebral hemorrhage, accounted for 45%. Now, if you're comparing with stroke data, you see that this appears to conflict with data from the Caucasians, where cerebral infarction accounts for like about 75%. So then hemorrhagic and hemorrhagic in terms of intracerebral hemorrhage and subarachnoid hemorrhage accounting for the rate. So what we're beginning to see in our environment is that more people are beginning to suffer hemorrhagic stroke. And I think the picture is not different from what we have here in the hospital here. Okay, so a few investigators have also looked at stroke at community level. And these are some of the investigators that okay, so these are some of the investigators that their work stand out. So Osun Toku. Then in Lagos, Danesi did a study, a community-based study in an urban mixed-income part of, an urban study in Lagos, somewhere I think around Mushi, and the prevalence he got was 1.4 or 1,000. Okay, so sorry about the technical glitch. I think that has been sorted. So thank you for your patience. Okay, so a few community-based studies have been carried out in Nigeria. So the first one was done by Osun Toku et al. So later Danesi between 2005 2006, where he got prevalence of 1.14 per 1,000. Then in the Niger data here, Professor Onwuchekwa 2013 published his own findings. So when the prevalence was 8.51 per 1,000, and I think he did this study around Ogoni. Okay, so this is picture of Professor Osun Toku. Okay, so so this is the image of Professor Osun Toku. I did a lot as far as neuroepidemiology in Nigeria is concerned. Okay, so talking about the risk factor, this is a landmark paper again, interstroke study, a powerfully designed case control study that looked at close to 27,000 participants and all that. So now this paper revealed that 90% of the causes of stroke are from about 10 risk factors. 10 risk factors, and most of them are modifiable. So you know what that means? So meaning that if you focus a lot of attention on those risk factors, so you'll be stemming, so mitigating the burden of stroke in our society. And this study took place in about 32 countries. And luckily for us here, Professor Guni contributed to it. Okay, so in another hospital-based study, Watila University of Maiduguri did a similar study, but this time around a retrospective study, so with a view to still highlighting risk factors for stroke. So one of the things that stood out in his finding was hypertension among the study subjects. So you can see where hypertension is. So, and this is actually a consistent finding. So in virtually every stroke that is designed to elucidate risk, you see where hypertension is. So it's alarming, and of course that further highlights the need to emphasize primary stroke prevention by addressing this particular risk factor. Yes, the truth is that in terms of population attributable risk for stroke, hypertension appears to contribute the most and all that. So if you are designing public intervention around stroke, so you target the one that makes the highest contribution. So that's why we don't joke with hypertension and all that. That does not mean that that's the only reason individuals will come down with stroke, but very, very important. Okay, so traditionally we classify these factors as non-modifiable and modifiable. Non-modifiable as those risk factors that, there's nothing you can do about them. There's nothing you can do about your age. You continue to grow old, and stroke incidence has been shown to increase with advancing age. Male gender males are more likely to suffer a stroke than females, race, Black, then even family history, then low birth weight. There's a correlation here between low birth weight and those that are going to come down with a lot of cardiovascular conditions in the future. Then under modifiable risk factors, hypertension still stands out there, then followed by diabetes. Ognitiri et al. 1983 demonstrated in a case control study again that hypertension still is one of the most significant risk factors for stroke. Then talking about diabetes, diabetics are twice more likely to have stroke than non-diabetics. And of course, the reason is clear. So these factors, these factors damage vessels. So so more seriously. Okay, so remember again, there are some other less well documented risks like alcohol use, alcohol intake, drug misuse. The relationship between alcohol intake and stroke is J-shaped. So mild to moderate use appears to confer some benefits, some protection, but as the individual continues to drink, so the relationship between stroke and alcohol now becomes linear, more so for hemorrhagic stroke. Then drug misuse is also another important factor we have to emphasize, especially in our time, with the upsurge of, the substance abuse here and there, miracle, cocaine, all manner of things people take. So these things can damage vessels, and predispose them to either ischemic stroke or hemorrhagic, especially stroke in the young. Infection environments. So this is also another area there's need for so much emphasis, because there have not really been anyway design studies in our environment looking at how environment predisposes to stroke, at least the mechanism behind that. But we know from literature that areas that are highly polluted, stroke is quite prevalent in such places. So let's look at gene and stroke. Certain genes have also been implicated. So chromosome 5, apolipoprotein E, Notch. So this is actually the one that's implicated in CADASIL, which is a stroke syndrome. CADASIL is cerebral autosomal dominant arteriopathy with subcortical infarctopathy. So Notch is implicated in this particular condition. Then CRITI gene mutation is associated with cavernous hemangioma. and a lot of other few conditions. Okay, so talking about stroke in the young, so I find this group of persons interesting because, I mean, if a young person comes down with stroke and he acquires a major disability, so you know the effect on that of that on the family economy, or even on his life, his destiny in general. I mean, so we really have to, we really have to, so look into this group of individuals, especially some of them that are known to exhibit some risk factors that can predispose them to stroke. So I will continue to talk about drug abuse. A lot of youths abuse drugs nowadays, and so that must also be this. Now, drug abuse is not actually the only reason that young people can have stroke. Remember sickle cell disease, arterial dissection, even some monogenic arteriopathies, a lot of other genetic conditions that affect vessels, so that can also make them to have stroke. Vasculitis, connective tissue disease, so on and so forth. Okay, I don't intend to waste our time discussing this. This is actually supposed to be an enlightenment program, so, but it's good to review you understand the anatomy of the brain. So the major vessels to the brain are derived from anterior posterior circulations, and so they converge somewhere at a point, where they participate in primary anastomosis called cycle of Willis. I'm sure you know about that cycle of Willis. There are other secondary anastomotic points, for instance, the posterior cerebral artery, the two anterior cerebral arteries joining somewhere, then a posterior cerebral artery, joining with a branch of the middle cerebral artery, internal carotid somewhere, and all that. So these are the secondary points. They also have the tertiary, anastomotic connections, especially so those you have in the leptomeningeal areas and other leptomeningeal. So why it's important is that it has a lot to do with who comes down with stroke. So even when two persons are exposed to the same risk factors, so one naturally comes down here than the other. And so one of the reasons is, so the details of this connection and how functional, so this network is too, and all that. So if a vessel is blocked at a point, so there is reconstitution by passing that particular point, trying to, so open up circulation and all that by passing that point of obstruction. So giving the brain time to, to heal or to readjust and all that. But if your anastomotic system is not good, once there is an obstruction, damage happens immediately, and so symptoms, begin to emerge. But important stroke, especially as far as clinical features, clinical presentation is concerned, it's good to also be conversant with motor homunculus. So this is simply the graphic representation of the different body parts on the brain. So the mouth area has its location. The mouth and the hand areas are close. The leg area, somewhere around the superior medial, aspect of the brain and all that. And so now, who comes down with what depends on the vascular territory supplying. Okay, so that's that part of the brain. Yeah, of course, middle cerebral artery, supplies most of the, the lateral convexity and all that, so, posterior, just somewhere up to a small pole in the occipital lobe. So it actually depends on the vessel, damaged. So, so that will determine clinical features. There are times you see patients in whom both face and the hand are weak compared to the leg. So that is middle cerebral artery occlusion. So in another scenario, you find someone with leg weakness more than the hand weakness. So that's going to suggest anterior cerebral artery occlusion. So in another group, you have individuals where weakness on both lower and upper limbs equal. So that's going to be what? Subcortical, stroke damage around the subcortical. area. So you see, so it's all in keeping with this anatomical this motor homunculus. So that actually determines the part of the body affected. Okay, so I don't think we need to delve into cerebral autoregulation. I don't think we need that. But yeah, I need you to understand that now the concept of cerebral vessel autoregulation is very, very important too. Now, what that suggests is that no matter the amount of blood pressure in the system, so a particular organ selects what it needs. So I think that's a simplification of this concept. Selects what it needs. So the vessels of the eye need a certain amount of pressure just for the kidneys and all of that. Okay, so now the more you put pressure on that system, maybe in form of chronic hypertension, so you are making that system less sensitive. So it's no longer able to select, and regulate blood pressure very well. And of course, you know what that means in the case of cerebral vessels. Now, the threshold for damage continues to reduce progressively until it gets to a critical point where something happens. Okay, so the form of occlusion or even hemorrhage. So in classifying stroke, yeah, so basically, I think we've alluded to that earlier, talking about infarction, hemorrhage. So in infarction, a vessel is blocked. Whereas in hemorrhage, a vessel ruptures. So now the next question is that in hemorrhage, if the bleed happens within the substance of the brain, you refer to that as what? Intracerebral bleed. Yeah, but if the bleed happens within the a space covering the brain, the area we refer to as what? Subarachnoid space, we refer to that as what? Subarachnoid hemorrhage. And the presentation is slightly different. Therefore, ischemic stroke. Now, this obstruction is not as simple as that. Is it like obstruction developing within the vessel? So that's the mechanism of atherosclerosis, mechanism behind atherosclerosis causing stroke. Okay, so atherosclerosis continues to happen, atheroma formation and all of that. So that gets to a critical point that a vessel finally blocks. Okay, there's yet another mechanism of cardioembolism. So where the heart is diseased, it's not able to expel blood, okay, regularly. And of course, one of the virtuous triad, where you have reasons for clot formation and all that. So vascular damage is one of those triads. What else? Disease and hypercoagulability. Okay, so anything that makes the heart not to be able to expel blood repeatedly is going to prolong the length of time the blood has to be within the heart. And of course, that's disease. And so clot forms. Now, each time contraction improves, those clots are dislodged, and follow different, vascular territories to the brain and all of that. Okay, so that's the concept of cardioembolism. There are other forms of embolism, for instance, artery embolism. So from a vessel, a clot dislodges, gets to a distant vessel and blocks it, and so artery. Then what about the issue of intracardiac shunt? Yeah, for instance, some of our patients that have PFOs too, that can have paradoxical embolism and all that. From the right side of the heart, clot gets to the left and thrown into so the systemic circulation, in this case, the brain and all of that. So these are different, conditions. Don't also forget about atrial fibrillation, arrhythmias, very, very important as far as cardiomyopathy is concerned. Atrial fibrillation and all that. Dilated cardiomyopathy, atrial myxoma, even left ventricular hypertrophy alone. So it's also a risk factor for stroke, still through the same mechanism. Okay, so in ischemic stroke, it's basically obstruction so that happens as in hemorrhage is a picture. And so now for intracerebral hemorrhage, there are sites that are usually predisposed to bleed, so especially the subcortical sites. And that's usually due to the nature of the vessel there. So a lot of subcortical vessels don't have very tough adventitia, tough fibrous tissue covering them and all that. Remember, these vessels pass through tissues, so they don't really need tough and all that. So, and highly sensitive to, blood pressure. So they can easily get damaged. And one of the consequences is bleeding in some of those important, areas around the bone, basal ganglia areas, and so on and so forth. Okay, so now I'm sure most of us are conversant with this BEFAST, FAST, facial weakness, arm weakness, speech impairment. Then call 911. But let me tell you the truth. This is actually an oversimplification of stroke features. Stroke can actually, stroke presentation can be more technical than this. Okay, so for the sake of, public enlightenment, I mean, it's good so we're conversant. So with this helps us to educate some of our relations in rural areas and all of that. I find in a place like the US, this comes in form of a jingle and the media. If you have fast, call 911 and all of that. And but I don't know how. So that's going to work in Ireland. But I think it's an important tip too. It's an important tip here. So, but the truth is that presentations of stroke are heterogeneous, and we'll be able to capture all of them in this discourse. So, but hemiparetic stroke appears to be one of the commonest presentations, and all that. But there are other representations, issues of chameleon, atypical stroke presentations. For instance, acute onset communicase aphasia. You are talking to somebody who's discussing something else. So that can be stroke, I may not be proven otherwise. Okay, so acute onset apraxia. Somebody who put on his clothes before is now struggling to put on his clothes. So remember in the definition, now it is not, nobody has told you must be weakness, acute onset neurological deficit in form of weakness. No, it's acute onset neurological deficit. That deficit can be sensory, it can be motor. Do you understand that now? So, and all that, even acute psychotic illness. Yeah, in an individual with, vascular risk can be stroke or to proven otherwise, and all that. Acute confusional state. So there are other typical ways stroke can actually present all that. So that we stop looking out for limb weakness all the times. Yeah. Okay, so among those uncommon presentations too, gestational syndrome, very, very important. Yeah, sometimes we see some of these patients in our practice, and that people present in a bizarre manner, having issue with the right, left disorientation, finger disorientation, and all that. Having issue with calculation, having issue with language use, all manner of things. That agraphia, not being able to even write. So these are also different atypical ways. Okay, so in the general workup of stroke, so what are our aims? We want to establish diagnosis of stroke in the first place. But it's not everything that looks like stroke is actually stroke. It's everything that looks like. Remember, there are a lot of other stroke mimics. Can be intracranial space of pine lesion. It's still going to present with hemiparesis and all that, but it's not stroke. So there is need for you to actually investigate to be sure that what is happening has vascular basis. So until then, you won't be comfortable establishing the diagnosis of stroke. Okay, so the second aim is to establish risk factors. So what risk factors predispose this patient to stroke? Any hypertension, diabetes, dyslipidemia, and a lot of, because these are the things we'll be addressing. Okay, so during secondary stroke prevention, so yes, you don't want your patient to come down with stroke again. Once the first one has happened, you don't want him to come down with another one. So you continue to address some of these risks. So again, investigation helps you to assess the extent of complications. Now, so in the history of stroke, it's important you pay attention to these questions. How did it start? How did it start? Talking about temporal profile. Stroke is usually acute in onset. Okay, so it's not subacute. It's not gradual. Okay, so yeah, tumor can be gradual, isn't it? Intracranial space of spinal lesion. But for stroke, it's acute onset. And of course, that's nicely captured in this definition, acute onset neurological deficit. So you have to be guided at this level and all that. So what's the lesion? Is it hemorrhagic? Is it ischemic? Where talks about localization. So is it in the anterior circulatory system? Is it in the posterior circulatory system? Are we dealing with posterior circulatory stroke? Are we dealing with anterior circulatory? So so this question helps you to, because each territory, different territories present with their different features. For instance, these symptoms apply to posterior circulatory obstruction or lesion, so to speak. Doesn't necessarily have to obstruction. So these symptoms, dysphagia, dysarthria, diplopia, so and all that. Was there a warning event, or was there an event heralding this final event? So that's the concept of what TIA is. So in the case of ischemic stroke. So remember that TIA and stroke are closely related. In fact, TIA is like the junior brother of stroke. So if TIA happens now, there's a way TIA is the risk for TIA is stratified. So TIA is not harmless. I need you to understand that. So TIA heralds the major event. So if TIA happens, treat it aggressively. If you don't, in a few months time, that patient is going to come down with stroke and all that. So please don't dismiss it. Don't dismiss TIAs. Okay, so what about sentinel headaches? So this applies to subarachnoid hemorrhage. Maybe an aneurysm is silently leaking, bleeding into subarachnoid space and all that, and patient is complaining of headache before the final thunderclap phenomenon that now ensues, and yeah, sometimes consciousness is lost and all of that. So this is going to suggest subarachnoid hemorrhage. Has there been any previous similar vascular events? Now, in your work, in your history, as you're asking questions around stroke, also try to ask questions around other vascular events. Also ask questions around other vascular events. Exclude coronary artery disease, because what is happening in one vessel can also be happening in another vessel. Yes. Also try the peripheral artery disease and so on and so forth. What other conditions could present like stroke? So this is where differential diagnosis of stroke comes in now. Assuming it's not stroke I'm dealing with, what else can it be? So don't forget seizure with neuronal exhaustion that results in thought paralysis. Can also present like stroke. So hypoglycemia can come with fleeting neurological deficits too. Can present this way. What about hemiplegic migraine? Some persons have migraine and are hemiplegic, so that may make you to think it's stroke, but whereas it's not stroke. So there are other, maybe also think about other stroke mimics. Stroke mimics, TIA mimics. There are also TIA mimics. There are transient globe amnesia, a number of things, also Adams-Stokes and all that. So these are TIA mimics. Okay, so but to establish diagnosis, imaging is very, very important. And CT is handy here. Not so many centers have functional MRI, but we're lucky here we have MRI. So a very good MRI for that matter, 1.5 Tesla. So that's sharing, So most other places, where I think the one they have here is around 0.5 and all that, and some other places, So, but yeah, so we have a very good one, here, which is good. Okay, so now, so the basis for this is, now some of these investigations are important in evaluating stroke. The truth is that if we were to be in civilized climes, once someone comes in, he's passed through these batteries of investigations. CT, angio, so depending on the type of stroke and the type of treatment they're contemplating for the patient. So CT, angio, MRI, so they go in that fashion. They check the vascular. So because what we want to do is to do what? establish, try to stratify that patient's risk. Yeah, for instance, carotid Doppler may reveal carotid stenosis. Yeah, it may not be critical yet, but it's something that, it might be something that will require aggressive medical therapy. But if you don't pick it at that particular point in time, you leave it till, because it's kind of significant stenosis. And before you know it, malignant infarction happens because a major vessel is going to get blocked and all of. So these are actually supposed to be, so what we do routinely. And I think for most of our stroke patients, those that can afford it, I think, it's time we started evaluating, so the carotid vessels and all of that, and I'll probably discuss further with the HOD so that we see how our patients pass through these things routine, so that we pick, we pick them. So remember that, some of them can undergo certain endovascular interventions, so that are going to help them later, endarterectomy, carotid endarterectomy, or even stent placement and all of that. So that will help to prevent major events. Okay, so don't also forget that certain investigations are important as far as identifying risk factors is concerned. ECG arrhythmia. Okay, so what about echo? It can be intracardiac clot, it can be intracardiac shunt, regional wall dyskinesis, left ventricular hypertrophy, all manner of things. Lipid profile, sugar, hemoglobin A1C, so on and so forth. Now, specifically for young individuals with stroke, so it's important to pay a lot of attention to issue of genotype, especially for those of them in whom you suspect sickle cell disease. Then homocystinemia, it's a metabolic reason for stroke again, so that predisposes to a lot of thromboembolic, phenomenon, a lot of thrombosis for the system. Then blood culture, toxicology screen, especially for substance abuse, for all manner of other medications that could damage vessels, protein CS and all that. So, okay, so this image summarizes different types of stroke. So the first one is ischemia. So the appearance here is hypodensity. So the second one is hyper, and the stroke is happening around the subcortical area. So, and then you also see kind of increased density around the perimencephalic areas and all that. So that's subarachnoid hemorrhage. Okay, so differential diagnosis of stroke. So there are a lot of stroke mimics. Some are structural, some are functional. Subdural hematoma, brain tumor. I think we've talked about some of this, even multiple sclerosis. And thought paralysis, migraine, we've talked about all this. Now, in managing stroke, don't forget the issue of resuscitation, our normal ABC resuscitation. Those that have cerebral edema, so attend to that. So mannitol is still useful, but don't be overzealous about. I personally don't give high dose mannitol. So there's a standard dose for that. So what I prefer, I usually use low dose mannitol. I may start out with something, high, maybe 200, 250, but thereafter I step down to 150, sometimes 120. Remember, mannitol is not completely harmless. Yes, it can be associated with all manner of things. Even acute renal failure, I hope you know that. It's a diuretic, it's an osmotic diuretic. So become overzealous about its use, you end up damaging kidneys. Even some dyselectrolytemia still can result from mannitol use. Okay, so the issue of blood pressure, I don't want to delve into this. There are a lot of issues about blood pressure management in stroke. I told us earlier that this is like enlightenment lecture. So my intention is not to delve into studies and so how we need to address blood pressure and all of that. But for hemorrhagic stroke, the latest guideline, so it's saying that BP targets in the first 24 hours should actually be 140/90 for hemorrhagic stroke. Yeah, so that may clash with what you already know. Yeah, but that's the what the guideline is. So for managing intracerebral hemorrhage. Okay, so now the essence of that is that it helps reduce hematoma expansion, which peaks within 24-48 hours and accounts for mortality and all of things. And so there are a lot of studies that you can look up at your spare time. INTERACT study, intensive reduction of blood pressure in acute cerebral hemorrhage and all that. So INTERACT study, ATTACK study. So these are studies that may guide you further. But for ischemic stroke, except you're doing thrombolytic treatment, take your time. Take your time, don't be in a hurry. Okay, except you're doing thrombolytic treatment. However, if systolic blood pressure is 220 and above, diastolic blood pressure, 120 and above, you can bring it down, but cautiously, and don't crash, So don't always be in a hurry to, crash blood pressure in ischemic stroke. But if you're doing intervention, okay, if you're doing thrombolytic treatment, so you have to, so make it around 180 or below, or 105 or below, and all that. Yeah, so you want to prevent bleeding and all that. So that's actually the essence of that. Okay, so you can look at this American Heart Association, American Stroke Association guideline for managing spontaneous intracerebral hemorrhage. So you can look at this article. It's going to help you with more information. Okay, so other things you don't need to ignore: fever wasn't outcome in stroke. Fever, pyrexia wasn't outcome in stroke. So it puts so much pressure on the cerebral metabolism and brain metabolism. So if you find pyrexia, please address that. Okay, pyrexia can happen in the setting of infection. It can also be central. Can happen in the setting of hypothalamic dysregulation and all that. So whatever may be the cause, if you find fever in stroke, please take care of that. Okay, so don't forget about seizure treatment, anti-seizure medications, DVT prophylaxis, then nursing care, so on and so forth. Okay, so stroke can be complicated by depression. Okay, so there are those that directly from injury to the brain, like seizures, depression, syndrome of inappropriate secretion of FAH, even cerebral salt wasting. These two metabolic complications are common in stroke, especially hemorrhagic stroke. Hemorrhagic, it can be intracerebral, can also be subarachnoid. Okay, so cerebral salt wasting, okay, as well as syndrome of inappropriate secretion. Yeah, so we also should be on the lookout for these two, complications, stroke. What about hemorrhagic transformation, which usually occurs with large vessel obstruction? Large vessel obstruction. Yeah. Most cardiembolic, mechanism, most cardiembolic strokes will obstruct very major vessels, and not small vessels. Okay, so you're talking about small vessel damage. You're talking about, those tiny vessels in the subcortical areas. Yeah, some of them are around pons, penetrating branches, pons. Penetrating branches of the basilar artery supplying pons, and maybe some areas in the cerebellum too. Those ones are hypertension usually affects them. Dyslipidemia, I think, diabetes too. Yeah, but for major obstructions, for major vascular obstructions, hemorrhagic transformation is one of the complications you look out for. So because it's also impacts prognosis negatively and all that. So, remember in the setting of, ischemia and hemorrhage happens from extravasation of blood, maybe from the perfusion changes and all of that. So the presence of that blood there, yeah, will trigger a lot of cascade of negative events. Do you understand that? So hemoglobin is poisonous, to neural tissues. Iron poisonous to neural tissues. So more negative events ensue, which will ultimately, was an outcome. So don't also forget brain hydration syndromes. Okay, so this applies to hemorrhagic strokes, depending on the location and all that. So it can be transtentorial sulfacine oncal, depending on the location of the hematoma. Look out for it. What about hydrocephalus? All that. So look out for this. So for systemic complications, your patients can aspirate, can have UTI, can have chest infections, venous thromboembolism, pressure sores, very important. Okay, so I think we've looked at this. Okay, so specific treatments for stroke. Now, so your goal for treating, especially ischemic stroke, is to do what? Reestablish perfusion. That's actually your goal. Okay, so, and under these, there are options. Options. Thrombolytic treatment is there, endovascular treatment. Of course, in our environment, some of these modalities are not readily available, and so we resort to conservative approach. So most times we manage our stroke patients conservatively, especially ischemic stroke. We manage conservatively and all that. So, but for hemorrhagic stroke, you're also managed conservatively, but occasionally you might, find strong indications to bring in neurosurgeons. Okay, so to help, yes. Some patients are going to have hydrocephalus, so in such patients there may be need for EVD, external ventricular drain, diverting CSF, kind of making sure it flows without further obstruction and all of that. That's known to improve outcome. Now, Stitch trial, has, it's an important publication, Lancet, has definite surgical indications in stroke. Yeah, for instance, hematoma, especially intracerebral hemorrhage. Hematoma very close to, I think, within 1 cm, very close to the calvarium, within 1 cm of the calvarium and all that. So can drain it and all that, and a lot of other things. Cranectomy, especially for massive cerebellar hematoma, so because we want to leave obstruction there, so the breast then can have space and all that. For subarachnoid hemorrhage, in fact, they can do a lot. Clipping, coiling, and all about it. Some of these things are not ready. Yeah, luckily, I think somewhere around they were able to successfully clip. We're able to successfully clip a stroke. There's a center in nowhere that can be done. Somebody had to come in to do that. And thrombolytic treatment is not here, even though, yeah, it can also be done in very few centers, where they've also been able to thrombolize. Now, the chemicals are here. The challenge you often have is patients getting to the hospital within the period. No matter how we stay abroad, the district to a hospital, police station, and all that. So if somebody, comes down with stroke, can easily dial 911, and ambulance is just, a few blocks away, can easily take the patient to the hospital. But here, our patients are coming from their villages. As a matter of fact, what they have is even, in fact, they may need people to convince them that this is actually true. So by the time they eventually get, you see that 2 days gone, 3 days gone, is that when you will start thrombolizing? Anyway, this is something that has to happen within a short period of time. So, but luckily for us, I think that window is getting extended now. World Stroke Organization was concluded a few days ago. So, and there are studies that I imagine that are even extending further to about 9 hours and so, but I don't have the details of that yet. But you see that there's hope for us. and all that. Such patients, they can make it to the hospital within 9 hours, and we might still be able to mobilize if they meet other conditions. The chemical is expensive, quite all right, but a lot of people can afford that. Okay, so endovascular treatment. The endovascular treatment is most uncommon. We pray that someday we'll start practicing this in Nigeria. So this is treatment modality gives opportunity to those that are not able to, present within, the time frame for thrombolysis. So in these individuals, so you're able to use catheterization, get to the brain, retrieve a clot, and all of that. But it's not as easy as that. So even in the advanced countries, so you only find this in a comprehensive stroke centers. So they're not in every area. A country like Pakistan has only one center that's endovascular eligible. Just to tell you what's involved. So the imaging system for this, is also a little bit technical. So because here you're going to be talking about CT perfusion,
I just feel it's all about
character. Viability, penumbra salvageable area, and all within a certain period, so that you don't go in and retrieve a clot. At the end of the day, the outcome will still be poor because you didn't select appropriately. Okay, so this is a little bit technical because we'll be considering a lot of other technical issues in the imaging. Mean transit time, Tmax, time to peak. So so we're not there yet, but we hope that someday we'll get there. So for now, we do conservative management. So occasionally we invite neurosurgeons to treat those with obvious surgical indications. So, so for ischemic stroke, we have our options for antiplatelets, but mostly we use aspirin, clopidogrel. That's in there. You're welcome, sir. So clopidogrel, but don't forget that there are other antiplatelets, dipridamole, ticagrelor, and all of that. We commonly use aspirin and clopidogrel. Okay, so now this is what the system of care for stroke should actually look like. But this is not from our environment. Okay, so now an event happens, you dial 911, an ambulance arrives at the scene. Okay. Now, the concept of stroke ambulance in the US started around Houston. So where an ambulance has the facilities for acute stroke imaging. Just call the ambulance, gets to the scene, so that some of those pre-hospital things, events and treatments can actually start, before patient eventually gets to the hospital. So still in a bid to do what now, save time and all that. Okay, so from there, triage there and 15 minutes. So you now see that within a very short period of time, so they're able to treat these patients. But again, I must tell you that it's not everybody that's got acute ischemic stroke that qualify for thrombotic treatment. So even in the best of, even in the US, those that eventually qualify for this may not be more than 30%. Because there are strict indications, a lot of contraindications for that. And so at the end of the day, still very few people. So endovascular treatment further widens opportunity for more treatments and all of that. But I just hope that someday we'll get here and all that, okay? Okay, so goals for stroke management. Now, so beyond acute care, don't forget the issue of stroke rehabilitation, because you want to help these people get reintegrated into the society as much as possible. So very, very important. In fact, this another area that requires a lot of emphasis. Yeah, because beyond our regular physiotherapy, there are a lot of other rehab programs. Okay, stroke patients can can access. Yeah, for instance, speech therapy, occupational therapy, even emotional therapy, spiritual therapy, and so many things, cognitive behavioral therapy, and all of that. So you want to, it's a life-changing event. It's a life-changing event. So you want to do your best to reintegrate them into society as much as possible, and all of that. There are so many things we are not able to do here, in terms of rehabilitation. For instance, our spasticity management is still low. So we don't do detox treatment, chemodenervation for spasticity and all that. We don't even do some advanced techniques, transmagnetic stimulation, and all that. I saw it for the first time in India, and I was shocked. You mean you could have all these things here too? So it's also a way of helping to retrain the brain, helping to put pressure on the neurons, and that's what we refer to as neuroplasticity. So with a view to achieving recovery and all of that. So we don't have some of these things here, but we'll get there. Okay, so the issue of secondary stroke prevention. Now, I told us that there's need to stratify patients' risk. Some of them take alcohol. They have to stop. They smoke, they have to stop. Weight loss, some other things. So these things really have to. So if you look at this diagram, you're going to see, so a few things that need to be addressed. So in the management of stroke, issue of diet, exercise should be encouraged. Sleep apnea should be taken care of, and all that. High cholesterol diet should be avoided. Okay, so so Mediterranean diet is said to be so protective for against stroke and all that. So I don't know how many of us eat this kind of food. Yeah, I don't know how many of us eat this kind of food. But, well, this is interesting. But I've actually, I don't look at this again. They said this one is brain food. So, but at least we can gather some of these things here. So the cabbage is there, apple, some of things. That's okay. So you're encouraged to eat a lot of these fruits and vegetables. Yeah. So, but don't also forget that our lowest hanging fruit here is actually fruits, vegetables, DASH diet. So it's the concept of DASH diet, dietary approach to stopping hypertension. So DASH diet emphasizes fruits, vegetables, legume consumption. I think Mediterranean diet is more exotic and expensive, and so not really available, but at least we can do DASH. So a view to stopping hypertension and all that. So I think I've talked about rehab, and all that. So stroke management, this is what the ideal situation should actually look like. So that bottle in the middle is actually altiplase, but we now have tenecteplase. Tenecteplase is more fibrin specific. So a lot of experts are tending towards tenecteplase now, and it's one dose injection. So, but this one will require you dose first. You're now doing infusion and all that. So people actually prefer that. Okay. So in the absence of the ideal, I think in the absence of the ideal, I don't know, consider young man is trying to revive a patient. Those are two electrical ions, in form of electrodes on the patient's chest, so trying to, improvise. So is there anything we can actually do to also improvise and to at least get, something working for us here? So don't also forget that stroke comes with a lot of poor prognostic features. Advancing age confers poor prognosis. Repeat stroke, uncontrolled hypertension, prolonged unconsciousness, aspiration pneumonitis, a lot of other things. But at the end of the day, about 25% of stroke patients are going to die following acute stroke. The 40% will have moderate to severe impairment and will require special assistance and care. About 10% of stroke survivors will recover completely. 25% will recover with minor impairment. And 15% will experience a second stroke in 5 years. Okay, so I'm about rounding off, but I found this paper interesting. I think it was done in Port Harcourt here, and quite recent too. And Dr. Wonder was one of the co-authors. Now, exploring essential care structures in tertiary facilities in Rivers State, Nigeria. So I think it compared, facilities here in Rivers State University Hospital with those at the University of Port Harcourt, so teaching hospital, and I don't know if you can see that well. So a lot of interesting revelations. Okay, so I think let me read from here. So at the time this study was done, only one neurosurgeon. Okay, so red is Rivers State University Hospital. So the other green is what? Green is what? UPTH. Okay, so at the time of this study, one neurosurgeon, Rivers State University Hospital, no neurologist. It's quite small. Okay, so if you run through, you see that UPTH has more physiotherapists. So we're only better in terms of our emergency response. We have more emergency staff, 26, UPTH 19. No, but in terms of physiotherapy, they have 49, we have 11. Clinical psychologists, we don't have, they have 4. Speech therapists, we don't have, they have 1. Occupational therapists, they don't have, we don't have. Dietitians, they have 9, we have 4. Social workers, they have 54, we have 5. So you now see that, I mean, these are remember, stroke care is multidisciplinary, and so these are the people with and all that. So there's need for us to work harder, so that we try to get some of these other health workers whose services are very important in the care of stroke. I will fail me to discuss this. Now, so the issue of stroke units too is practically non-existent around here. Yeah, here, University Hospital doesn't have, University of Port Harcourt Teaching Hospital doesn't have, and all that. But remember, stroke units is associated with improvement in chances of survival. It reduces, disability, shortens length of hospital stay, also shortens length of rehabilitation. So, and the reason for this is that, so in stroke unit, you have multidisciplinary approach to stroke care. So you have everybody. Nurses are stroke nurses, physiotherapists and neurophysiotherapists. You get that. So thrombolytic treatment happens there. Surveillance, complication surveillance is very strong. They can easily detect when somebody has come down with bedsore, and you try to be proactive about that. So you see that at the end of the day, these things will ultimately result in improved care. And so you see that management of stroke in stroke unit is far better than in a general word for obvious reasons. Okay, so a survey recently was done. I think I read this paper a few months ago. Arabambi, Lagos State University Hospital is now in Canada. It just did a survey of stroke unit structures and organizations in Nigeria. So it looked at the different geopolitical zones. Alex Ekweme, Federal University of Technology, that's Abakaliki, University of Ilori, Benin, LASUT, LUT. So Alex Ekweme, they established their own stroke unit 2021, Ilori 2012, UBTH 2010, LASUT 2019, Lagos State University Teaching House, Lagos University House 2017, number of beds for Abakaliki 10. So you now see the breakdown, and you see the Niger Delta is not represented here, especially Port Harcourt and all that. So we need to also be part of a similar study, so where we can boast of a stroke unit. Okay, so to emphasize again the multidisciplinary nature of stroke care, you can see, it's a construction site, somewhere abroad. So you see all the people that are involved. As a project manager, as a logistic manager, marketing, you start asking yourself, what is the marketing manager doing in a construction site? But that's how they work. And we also need to work that way here in managing stroke, where we have, everybody around with different people playing their different roles. But in absence of that, you can always design your own comforts regardless of your status. So this is a small boy improvising a cushion with a few blocks. And I mean, as far as he's concerned, he's comfortable and all that. I mean, so maybe we may resort to, I don't know. So now, unfortunately, okay, so yeah, I like this quote. I saw it recently. You never change things by fighting the existing reality. So to change, unfortunately, I think it's getting uploaded. So what he's saying is that to change something, you evolve a model that makes the existing practice that makes it irrelevant. Okay, so automatically, I mean, you leave the old and embrace the new and all that. So I think this should actually be our current thinking now. So how do we make things better? Not by fighting the existing limitations, but by evolving something. So in form of disruptive thinking, evolving a system, a method that makes what is already on ground, that makes it like child's play, so that makes it ridiculous. So I think that is it. So in conclusion, stroke is a common neurological disorder and the burden is quite high. Primary prevention is the key to reducing the burden of the disease in a country with such poor resources, as early hospital presentation improves outcome. So there is need to save the precious time. Okay, so before I bow out, I need to take our time to acknowledge our able chairman, NMA chairman, for taking our time to take this program, our HOD too, and all of you that are seated. I celebrate each and every one of you. So you're part of the success of this presentation. So, but in addition to that, a few persons have actually impacted my life in neurology. So that's Professor Danesi there. So I learned neurology under him, and so this is Professor Kubadejo. Yeah, she taught me a lot of movement disorders. So this is Professor Manta. Yes, I was with her in India. She taught me a lot about epilepsy and all that. And so the last one is Danish Bhatti. Danish Bhatti is in Florida. He also taught me a lot about movement disorder, and are great mentors. I really celebrate them. So thank you for your time, and thank you for your
Thank you very much. We'll just take 2 questions, and we have questions from the online platform. Every other question here, we'll answer during morning review on Wednesday. First question is, are there features that are specific to ischemic or hemorrhagic stroke?
Okay, yeah, thank you for that question. Yeah, I'm going to say yes. I'm also going to say no. Yeah, so in hemorrhage, so because of a kind of increase in intracranial pressure following rupture of a vessel, so you expect that symptoms are going to evolve fast, very, very fast, okay? Of course, those symptoms are going to be in keeping with what? Elevation intracranial, sudden elevation in intracranial pressure and all that. So yes, vomiting, a lot of patients with hemorrhagic stroke are going to vomit, they're going to have headache, so become unconscious and all that within a very short period of time. Yeah, so to that extent, yeah, I'm going to say, but again, yeah, in my practice, or in our, so we've also seen a lot of patients with hemorrhagic stroke with very tiny hematoma. And they're normal, talking with you, no headache, nothing, only neurological deficit, So you think you're dealing with ischemia. And of course, that's why we emphasize neuroimaging, but you can never really be sure. Sometimes we are lucky, it's a massive, hemorrhagic stroke and symptoms evolve over a very short period. In other cases, I mean, maybe just very small hematoma, not enough to, compress tracts and consciousness is intact and all that. So if you don't image, you wouldn't know. If you don't image, you will start giving aspirin to the man that has got hemorrhage. You start anticoagulating, you start doing what you shouldn't do, and all of that. So in the past, pre-imaging era, Cyrillic scoring system that was designed, in Asia, to help distinguish between ischemic and stroke. But I can tell you that in this imaging era, nobody talks about CRAD score. Nobody talks about CRAD score. You know, it was designed those days. The CT scan, you know, the CT scan was manufactured around 73, MRI maybe around 71. Okay, so that period there was no imaging. So people now try to find a tool, a clinical tool to help distinguish, but we don't really talk about that. So the teaching now is that go and image. Go and image. Okay, so.
All right, thank you very much, sir. So the next question is, what is your take on starting monitor when a brain CT scan result is not out to determine if it's ischemic or hemorrhagic? What's your take on that? Okay,
so now instituting osmotherapy is not dependent on the result of brain CT or hemorrhagic. I'm sorry, on the result of the brain CT, whether it's this or that. You know, that decision is based on the clinical features there. It depends on, I mean, that decision is taken based on patient's clinical features. So once there's evidence of elevation in intracranial pressure, you can do osmotherapy. And that can happen in both ischemic and hemorrhagic. If, for instance, someone with malignant infarction, with very large perilegional edema, so you can do small osmotherapy. So, I mean, you don't necessarily have to. So, but in that, I mean, if somebody comes with ischemic stroke, or even hemorrhagic stroke, and is stable, talking with me, no evidence of elevation in intracranial pressure, you know, consciousness is not clouded, no headache, no this, no that. So why would I mean, mannitol is not, you know, it's not a magic bullet for every case of stroke.
What factors make the black race predisposed to stroke?
Okay, so I'm afraid this question is slightly, you know, yeah, it's beyond the scope of this discussion. Yeah, so I think what I've tried to do is to present epidemiological evidence. So, but in trying to understand biological plausibility, so it requires more detailed studies, you know, some of which are going to happen at genetic level, you know, so where you compare blacks with others. But epidemiologically, you know, so many things. Our health system is poor. Health insurance, you know, risk factor prevention is not so strong there. So our healthcare is out of pocket. Most of us pay for our so at that level, but there may be more things. There may actually be more things, you know, so at the level of the genes. Okay.
All right, sorry, and that question, someone is saying, is there any protocol for the management of stroke in Nigeria? As most of the drugs and imaging technologies are not available in the country. Also, some Nigerian patients cannot afford CT. He's asking whether there is any protocol.
Okay, so yeah, there's no national protocol. There's no national protocol, so to speak, you know, but protocols are individualized. Now, so our holy script for that is the guideline. Okay, so but again, you see, you don't follow guideline. Guidelines are not sacrosanct. So you modify guidelines to what is available, you know, what's available in your local environment. Okay, for instance, selective place is not readily available. We're not going to formulate a guideline that will incorporate that because we don't have it. And all that, yes.
So, sir, please, another question: how can we differentiate stroke from hypertensive encephalopathy?
Okay, so stroke and hypertensive encephalopathy are quite close in presentation. Okay, so the basis for the mechanism of hypertensive encephalopathy is sudden onset, you know, vascular dysregulation. So the autoregulation is not working well again because of sudden elevation in blood pressure. Okay, so making capillaries leaky. So and resulting in fluid extravasation into the brain substance, predisposing to edema, which is akin to what happens in eclampsia in women. Okay. Okay, so where sudden rise in blood pressure so results in a similar thing, even though it happens at a lower BP and all that. So sometimes it's actually difficult, okay, to say which one is which. Even for those with encephalopathy, still image them. If you are lucky, some of them have, lateralizing signs. So that may be enough guide that, yeah. So beyond the encephalopathy, you're not dealing with a so-called otherwise. Go ahead and image. Some of them may not have been lateralizing sign.
All right. So I think because our presenter today deserves a standing ovation. Thank you for all you've done for us and also for causing a great impact. I'm sure when the study was done, you see very well that there was no neurologist. Now we have a neurologist and we have other neurologists coming. So let's put our hands one together to get All right, so thank you very much. Let's just sit down. So very briefly, we are out of here. As we conclude, I want to just say a very big thank you to the NME Rivers State for this wonderful collaboration. That was one of the reasons why during the campaign, we made a lot of promises. And today we also have the NME Chairman, Rivers State, my boss, Dr. A.B. Robinson, a consultant radiologist here. Let's put our hands together for him as he gives the final closing.
All right, good morning, senior colleagues and colleagues. On behalf of the State Officers Committee of the Nigerian Medical Association Rivers State Branch, I want to sincerely appreciate and thank the Department of Internal Medicine, firstly, to the head of department for putting together this study and for this collaboration with the Nigerian Medical Association. So I want to quickly thank the head of department, Professor Chizindo Aleko, for this program. I also want to appreciate our guest speaker, who is now one of us, for coming up and celebrating the World Stroke Day with us. The lectures were quite educative. The lectures were quite inciting. It was a good insight to what exactly is happening and the epidemiological representation of stroke in our environment. We are believing that moving forward, and from what we've heard, we will be able to manage our stroke patients better with the information we already have. So, sir, I want to sincerely, on behalf of the Nigerian Medical Association, thank you very much. And I'm believing that moving forward, similar collaborations with other departments will be going on, and then everybody will be better off, especially with the management of our patients. I just want to add that as a radiologist, if I don't just say some few things concerning the management of stroke in our environment, I wouldn't have done justice to my stay here. And I wish to say that we are blessed somewhat to have at least a 1.5 Tesla MRI under our usage. And with that, we can be able to do a lot of things. I know outside this country, in some areas, there is 520, 126 light cities, and there are about 3 Tesla MRIs. But at least when it comes to South Nigeria, we are one of the best, and we can showcase one of the best radiologic facility in South Nigeria. So that is a plus to us. And so we can use radio imaging so much in the diagnosis of our patient. Now, let me just quickly say for the purposes of academics, that there is what we call stroke protocol. That is a stroke protocol. And for those going to, especially for the Part 2 students, we must understand what is the difference between a protocol and a sequence. So when we talk about T2, T1, diffusion weighted images. These are sequences. These are MRI sequences. But when you put multiple sequences together, you now get a particular protocol for a particular disease. So the protocol for a brain tumor will not be the same as the protocol for stroke. For instance, by virtue of a hallmark, if you want to do and get bleeding, no matter what the level of bleed is, you must do a diffusion weighted image. So DWI is the standard protocol that must be included for you to say there is a bleed. For you to say there is an infarct, there must be a flare, fluid attenuated inverted recovery. So these are basic and standard protocols we must understand that comes with MRI. If we are being bedeviled with a scenario where somebody had a sudden fall and we think that's an hemorrhagic stroke, and we say, oh, MRI takes a lot of time, why not we do a CT? If you do a CT, no problem, you can still see the bleed. But the standard hallmark is what? MRI for the sake of a diagnosis, and we must, get that. And with our 1.5 Tesla, we can do a lot of things. We can do what we call time of flight. So we can also do an angiography without giving a contrast. Okay, using what we call the high intensity, projections, the maximum intensity projections. So we can use all this to look at your vessels without necessarily giving anybody, contrast agent. So on this note, I want to say that I sincerely appreciate all of us, and my department is very ready to always collaborate with the Department of Internal Medicine to ensure that we give our patients the best. So I want to celebrate with us on this World Stroke Day. The whole ideology is to prevent stroke, and let's look towards preventive care than what? Curative care. Thank you, and God bless everyone.
Thank you so much, Chairman. And just before we round up, I think I want to hand over to Dr. Success Obamba, Senior Registrar, Neurology Unit, so that she tells us the next modality for the program. Dr. Success, what plans do you have for us?
Okay, good morning, everybody. Please, so I thought I will just, with a banner.